Hello, I am Dr. Sandeep Salvi, the Director of the Chest Research Foundation situated in the city of Pune. I am going to share with you today the importance of spirometry in diagnosing obstructive airway disease, understanding the basics and how to interpret the spirometry report. The lung has been given the responsibility of nourishing the body with oxygen. The oxygen that we take through the lungs produces about 90% of the body's energy on a daily basis, with only 10% of the energy coming from the food that we eat and the water that we drink. And therefore, the lung plays a very important role in supplying oxygen to all the cells of the body. In order for this to happen, various parts of the lung have to function properly. You need to have patent airways so that air can easily go in and out of the alveoli. You need to have a large number of alveoli so that there are sufficient alveoli to soak in the oxygen that is present in the air. And then you need to have a very thin alveolar capillary membrane through which oxygen diffuses into the blood. If you have to study the lung function, you have to study the functions of all these three components of the lung. Among these, measuring the airway patency is perhaps the most widely used test in clinical practice. So if you want to find an answer for are the airways patent, the most useful diagnostic tool is spirometry. And this is what I'm going to focus all my talk on with this. For many years, people have been trying to measure the volume of air coming out from the lungs after taking a deep inhalation, but they were not very successful until about 1727, when Stephen Hales from the United Kingdom used a very simple logic. After taking a deep inhalation and filling the lungs with a lot of air, he asked the patient to blow into the balloon all the air that was present in the lungs. So after he captured all the air present in the lungs, he measured that volume by using the Archimedes principle. He filled a tub right up to the brim with water and then pushed this balloon inside the tub. The excess volume of water that came out was exactly equal to the volume of air that was present in the balloon. So this water displacement principle was the first technique that was used to measure the volume of air coming out from the lungs. It was Sir John Hutchison in 1846 who developed this technique even further and formed what we now call as a first spirometer. Sir John Hutchison is the same physician who is associated with the book that we use in second MBBS called Hutchison's Clinical Methods. He is the same person who invented the spirometer. He used the same principle of water displacement. So instead of a tub and a balloon, he just used a drum and filled that with water. And as the subject blew air into the drum, there was a displacement with the water and a graph was produced which measured the volume of air coming from the lungs. The volume of air that one exhaled after taking a deep inhalation was what he called as vital capacity. And there is a reason for why he called it as vital capacity, because he was able to show through a very big research study that that volume of air was directly proportional to the lifespan. So the more volume of air you could remove from the lungs, the more your lifespan was. And therefore he said that this volume of air was vital for survival, and therefore he called it vital capacity. He was also able to show that this vital capacity was a very good predictor not only of survival but was also a very good diagnostic indicator of underlying tuberculosis, although that is not much talked upon nowadays. If you remove that volume of air from the lungs slowly, he called it as slow vital capacity, and if you remove the same volume of air from the lungs with force, he called it as forced vital capacity. So there are three terms that I have introduced to you now: vital capacity, slow vital capacity and forced vital capacity. For about 100 years, this was the only parameter that was used to measure lung function. Vital capacity, either slow vital capacity or forced vital capacity. About 100 years later, Tiffinot from France came up with a very bright idea. He said, why don't we split the forced vital capacity and give it a time domain? In the sense, if all that volume of air comes out of the lungs in say 3 or 4 seconds, then what is the volume of air that came in 1 second? What is the volume of air that came in 2 seconds? And by doing so, he was able to find something very interesting. The volume of air that came out of the lungs in 1 second, that he called as FEV1, was significantly reduced in patients who had obstructive airway disease. And then he was able to show very clearly that the ratio between FEV1 and FVC was significantly reduced in patients with obstructive airway disease. So, Sir John Hutchison started with vital capacity and called it as forced vital capacity if you removed it with force, and then Tiffinot introduced the term FEV1 or forced expiratory volume in 1 second. What is the logic behind the reduction in FEV1 that is seen in patients with obstructive airway disease? Very simple. If I give you a big straw and if I give you a small straw and ask you to take a deep breath in, fill your lungs with as much air as possible, and then forcefully remove all the air out through the big straw, and then I asked you to do the same thing with the small straw, do you think you will find a difference? Obviously. If you blow through the big straw, all the air will come out very fast because it's got bigger lumen. On the other hand, if you blow through a smaller straw, it will take long time for the same volume of air to come out. And this is a simple principle that spirometry uses in diagnosing obstructive airway disease. Just imagine that your big straws in your airways are replaced with small straws, and therefore it takes more time for the air to come out. Let me show that to you through a very simple cartoon over here. On the right hand side on the top, you can see a cloud-like picture, and the cloud-like picture is actually the total of all the alveoli present in the lungs, and then there is a tube that is connected to that, and that tube is the representation of all the airways that are present in the lungs. Now imagine that this is of a normal healthy person, which means that the airways are nice and patent. So we ask this person to take a nice deep breath, fill the lungs with as much air as possible, and then blow out forcefully. Did you see how fast the air came out? Now let me show the same thing to you in a graphical format. So here is a person who takes a nice deep breath, fills the lungs with as much air as possible, and then forcefully removes all that air out. And there it is. He has removed 4 liters of air from the lungs, and therefore the 4 liters represent his forced vital capacity or FVC. Now let us dissect that FVC using a time component. On the x-axis I have time in seconds. The volume of air that you remove in 1 second is called FEV1. Volume of air that you remove in 2 seconds is called FEV2. In 3 seconds, 4 seconds, 5 seconds and 6 seconds. I want you to observe 2 things over here, very important. After how much time did all the air come out from the lungs? In the sense, when all the air comes out, you reach a plateau and there is no more air that comes out of that, above that. So you can see in this graph that after 2 seconds there is a plateau, which means that in a normal healthy person, all the air comes out by around 2 seconds, maximum 3 seconds. And then after 2 or 3 seconds there is a straight line called as a plateau. That is very important for you to see. The second observation that I want you to make is, if you look at the ratio between FEV1 upon FVC, it will always be more than 70%. And therefore 70% is usually taken off as a cutoff value to diagnose obstructive airway disease. If FEV1 upon FVC is less than 70%, for all practical purposes, it is indicative of obstructive airway disease. So 2 things again that I wanted you to see: a plateau that is reached by around 2 to 3 seconds, and FEV1 divided by FVC is more than 70%. Okay. Now I will show you what happens in patients with obstructive airway disease. So again you have the cloud that represents the alveoli, and then you have the tube that represents the narrowed tube present in patients with obstructive airway disease. Take a deep breath in and blow out forcefully. Did you see how long it took for the air to come out? Obviously, because the airway was narrow. It took a long time for the air to come out. And the same thing I can show you in the same graphical format. In a person with mild to moderate obstructive airway disease, the FVC does not change. So in this patient, you get the same FVC value as that of a normal healthy person. So what is the difference? The difference is in the time domain. Look at what happens to FEV1, FEV2, FEV3, FEV4, FEV5, FEV6. So what are you seeing over here? In the normal healthy person, all the air came out in 2 seconds. Here, it took 6 seconds for all the air to come out. And that is what I want you to appreciate. That if you have obstructed airways, then it takes a long time for the air to come out. It takes about 6 seconds. And what is the second thing that I want you to observe? The FEV1 upon FVC ratio is less than 70%. Simple. That is the simple principle that spirometry uses to diagnose obstructive airway disease. So here is a graph called as the volume time graph. There are 2 graphs that you get in spirometry. The volume time graph is a graph that shows volume on the y-axis and time on the x-axis, exactly the same as what I showed you in my previous slide. The volume of air that you remove in 1 second is called FEV1, as you can see on the y-axis, FEV1 in liters, and the maximum volume of air that you have removed from the lungs, the place where there is a plateau, that volume of air on the y-axis is called FVC. And you can see that FEV1 upon F and FVC are very close to each other. On the x-axis, you can see the time in seconds, and you can see that the patient blew for about 6 seconds. So how long did the patient blow for is what will be captured in this parameter called FET, or forced expiratory time. And it's very useful, very important for quality assurance when you start interpreting. The second graph that you get in spirometry is called as the flow volume loop. In the flow volume loop, you have the flow on the x-axis and the volume on the y-axis. Remember, in the previous one, the volume was on the y-axis. Here the volume is on the x-axis. Here you get a loop-like image where the upper portion of the loop, which is the expiratory loop, looks like a triangle, and the lower portion of the loop looks like a semicircle, is the inspiratory portion of the curve. So expiratory is a triangle, inspiratory is a semicircle. Just remember that. Because volume is on the x-axis, the point that is furthest to the right, as you can see on the x-axis, is the FVC. Okay. Now if you look at the flow axis, the maximum flow that you reach during an expiratory portion of the curve, that top portion right on the top, is what you call as the PEFR, or peak expiratory flow rate. Okay, that's the peak flow that you have reached, and this is the same value that you get in a peak flow meter. On the y-axis, there is another parameter called FEF 25 to 75. What is this FEF 25 to 75? On the x-axis, you can see that the FVC is from 0 to the right. Now divide this FVC into half, which is 50, 25% and 75%. Then from 25% and 75% you draw a line upwards and then connect it to the flow portion on the y-axis. So the average flow between 25% of the FVC to 75% of the FVC is called FEF 25 to 75. Okay. So which are the parameters that we get in a flow volume loop? You get the FVC, which is on the x-axis, and on the y-axis you get 2 parameters, PEFR and FEF 25 to 75. Okay. What I really want you to appreciate is the fact that from the point of PEFR to FVC, you can see the flow coming down slowly, but it comes down in a straight line, as if it is drawn with a scale. And I'll tell you the importance of observing this. So what does spirometry actually measure? Spirometry measures 2 volumes and it measures 2 flows. It measures FVC and FEV1, which are the two volumes, and it measures PEFR and FEF 25 to 75, which are the two flows. 4 parameters that give you everything that you want to know about spirometry. And then there is a fifth parameter, which is the ratio between the two volumes, FEV1 upon FVC. And remember, I told you that if FEV1 upon FVC is less than 70%, for all practical purposes, that is used as a diagnostic criteria for obstructive airway disease. Okay. The spirometer has various types of flow sensors. You have the pneumatag based flow sensor, you have the anemometer based flow sensor, the turbine, and the ultrasonic based flow sensors. So these are the different flow sensors that measure flow, and then flow is then converted into volume using highly sophisticated mathematical equations. How do you interpret spirometry? For that, I have just put in front of you an electrocardiogram, and I would like you to tell me what is the diagnosis of this patient. I am sure many of you all will make a diagnosis within 3 seconds or 4 seconds, and you will be right most of the time. This patient obviously has anterior wall myocardial infarction. But when you were taught about how to interpret an electrocardiogram, I am sure you were taught to look at 20 different parameters. So how did you look at all those 20 parameters in 3 seconds? Difficult, isn't it? But still you are so confident that this patient has got an anterior wall myocardial infarction. You did that because you looked at the shape of those curves, and you're confident that if you see that ST segment elevation, the T wave inversion, you know for sure that this is a patient with myocardial infarction. Now, so you made a very, very big diagnosis just by looking at the shape of those lines, and I'm sure you're confident about that. Can you tell me what the diagnosis of this patient is? There are two graphs over here. You have the flow volume loop and the volume time graph. Can you make an interpretation of this? Perhaps many of you all may not be able to make an interpretation because many of us are not taught how to interpret spirometry by looking at these curves. Let me share my secrets with you about how to interpret spirometry by looking at the shape of these curves. Now, before you really start interpreting, I really want you to go through this checklist. First and foremost, make sure that the patient blew for at least 6 seconds. If the patient did not blow for at least 6 seconds, do not interpret the test, especially if you are suspecting the patient to have an obstructive airway disease such as asthma or COPD, and I'll tell you why in the next slide. So once you have checked that patient has blown for 6 seconds, okay, then I will go ahead with making my interpretation. If the patient has not blown for 6 seconds, don't interpret it. Throw that report away, because chances are that you will make a wrong diagnosis if you look at the values within this patient. So then you look at the volume time graph, then you look at the flow volume loop, and then finally you use a simple diagnostic algorithm that I'll show you later on. So here is the importance of 6 seconds. Now imagine that this was a patient who had underlying asthma, and while performing the spirometry test, the patient only blew for 2 seconds. Now 2 seconds was not enough to remove all that air out. So what are you seeing over here is, you see a false low FVC because the patient did not blow for longer than 2 seconds. So had he continued to blow for more period of time, he would have removed more air out. But because he did not, his FVC value is now falsely low. Now if you look at the ratio between FEV1 upon FVC, you will see that it is 78%. More than 70%, so it is not obstructive airway disease. And then you will say that FEV1 value low, FVC value low, ratio more than 70%, so this is restrictive lung disease. You are suspecting this patient to have asthma, but the report is coming as restrictive lung disease. The patient does not have restrictive lung disease. It is a wrongly performed test that gives you a wrong diagnosis. Now, had this patient continued to blow for 6 seconds, the FVC would have been much higher, as you can see over here. That would have been the true FVC. And now if you look at the ratio between FEV1 and FVC, you will see that it is less than 70%. Now you are making the correct diagnosis. Therefore, if you do not blow for 6 seconds, then you will certainly make a wrong diagnosis in these patients. Here are a few tips. If the patient continues to remove air for 6, 8, 10, 12, 15 seconds, my God, you can only imagine how much airway obstruction he must be having, because he is taking such a long time to remove that air out. A normal healthy person removes all the air out in 2 to 3 seconds. Here even at 12 seconds he is removing the air out. You don't even have to look at the report. This patient has got severe obstructive airway disease. Now here is how you make an interpretation of the volume time graph. On the y-axis you have the volume in liters, the x-axis you have time in seconds. And I have shown you the graph of a normal healthy person. You have the FEV1 and the FVC values over there. Now when this person develops mild obstructive airway disease, this is how the line looks like. What has happened to the FEV1 value? It has become slightly less than that of a normal healthy person. What about the FVC value? The same as that of a normal healthy person. Is there a plateau that is reached? The plateau starts appearing at 5 seconds. Can you see that? In a normal healthy person, the plateau appears at 2 seconds. Here, the plateau is appearing at 5 seconds. So, a slightly low FEV1 value, a plateau at around 5 seconds is mild obstructive airway disease. As simple as that. Now, when this patient develops moderate obstructive airway disease, this is how it looks like. FEV1 becomes more low, FVC is achieved close to that of a normal healthy person, but there is no plateau for even at 6 seconds. This is characteristic of moderate obstructive airway disease. Now, when this person develops severe obstructive airway disease, this is how the line looks like. You can now appreciate that the FVC value has significantly reduced, right? So, from the top, it has come down. FVC value is at the bottom over here. Why is the FVC value reduced in patients with severe obstructive airway disease? That occurs because in these patients, when they start blowing forcefully, the small airways collapse. When the small airways collapse, air that is distal to that in the alveoli gets trapped inside the lungs, and that air does not come out, and therefore you get a low FVC value. So this patient already has a very low FEV1 value, has also got low FVC value, and there is a direction of the curve that goes up and up and up and up and up forever. If you see this curve, you know that this patient has severe obstructive airway disease. So isn't that simple? By merely looking at the shape of those curves, you can make a diagnosis of obstructive airway disease, and you can even tell whether it is mild or moderate or severe. If you think this is simple, then the flow volume loop is even simpler than this. And here is what the flow volume loop of a normal healthy person looks like. As I showed you, the expiratory loop is a triangle shaped one and the inspiratory loop is a semicircle. Now let us focus only on the expiratory curve, which is a triangle shaped one. The point on the top, the maximum flow that you reach is the PEFR, and the point at the extreme right on the x-axis is your FVC value. And I told you that there is a straight line between PEFR to FVC, and that is what we see in a normal healthy person. Now when this person develops mild obstructive airway disease, this is how the line looks like. What has happened to the PEFR value? No change. What has happened to the FVC value? No change as compared to that of a normal healthy person. So what is different over here? Can you see this concavity? That curve between PEFR to FVC? That concavity that appears is indicative of obstructive airway disease. And if this concavity is present with a normal PEFR and a normal FVC, this is mild obstructive airway disease. When this person develops moderate obstructive airway disease, this is how it looks like. PEFR value has gone down, FVC value has not changed much, very close to that of a normal healthy person, but the concavity has become even more. Moderate obstructive airway disease. And in severe obstructive airway disease, you can appreciate that the FVC value has become less, and I told you why. You get a low FVC value in severe obstructive airway disease. The PEFR value has also become less, significantly less, and more important, you can see the nice right angle concavity. So this is indicative of severe obstructive airway disease. Low PEFR, low FVC, and almost a right angle curve over here, right angle. is indicative of severe obstructive airway disease, classically seen in patients with emphysema. You see this shape of the curve and you know that this patient has emphysema. Okay. So, let me show you two graphs and let me see if you have understood how to interpret the spirometry by just looking at the shape of those curves. So, this is a normal person spirometry and this is your patient's. Does this patient have obstructive airway disease? Yes, no. If yes, is it mild or moderate or severe? Can you see the PFR is slightly reduced? No change in FVC. Can you see the curve? The moment you see a curve, this is obstructive airway disease. Low PFR, moderate obstructive airway disease. And here is another curve for you. Does this patient have obstructive airway disease? Yes. Why? Low peak flow, low FVC and a right angle curve. This is severe obstructive airway disease. I hope you all were able to capture both these results. Now, once you have made a diagnosis of obstructive airway disease, which we know that it is less than 70%, FEV1 upon FVC is less than 70%, you need to know whether this is asthma or is this COPD. You know how we differentiate over here? You give this patient a short-acting bronchodilator drug like salbutamol in a dose of 200 to 400 micrograms and then repeat the spirometry after 15 to 20 minutes. Now, if you find that the ratio, which was less than 70% before, has now become more than 70%, then this is asthma. And if the ratio has remained less than 70%, even after giving a bronchodilator drug, then this is COPD. In fact, a post-bronchodilator FEV1 upon FVC ratio of less than 70% is the defining criteria for COPD on spirometry. Okay. Once you have made a diagnosis of obstructive airway disease, the other way you can sort of confirm whether this is asthma or COPD is to look at what happens in FEV1, the reversibility. It is called as bronchodilator reversibility, but you use FEV1 as a parameter over here. So, after giving salbutamol, if the FEV1 improves by more than or equal to 12% and more than or equal to 200 ml, this is indicative of good bronchodilator reversibility. And a good bronchodilator reversibility is indicative of an underlying diagnosis of asthma. Okay. If you want to determine the severity of the obstructive airway disease, then you use the FEV1 percentage predicted value. And here is how you do that, which I will come to in a subsequent slide. Now, before we do that, here is a graph of a patient, pre-bronchodilator and post-bronchodilator. Pre-bronchodilator is in red, post-bronchodilator is in blue. You can see the volume time graph and you can see the flow volume graphs. Those red dots, do you see that? So, the one on the left hand side, the first dot is the predicted FEV1 value, then this is the predicted FVC value. And now you can compare to the predicted FEV1 value and predicted FVC value, how low is it. And in the subsequent, the one next to that is the flow volume loop. The green dot on the top is the PFR. The green dot at the extreme right is FVC, and then you have FEF 25, FEF 50, FEF 75. Okay. What can you see in this patient? Just look at the red lines. Does this patient have obstructive airway disease? And after giving a bronchodilator, do you think that there has been significant improvement in these values? There has been, isn't it? So, this is a classical case of asthma. Obstructive airway disease with good bronchodilator reversibility. You can see the big change that has occurred in the FEV1 values and the PFR values and FEF 25 to 75% of the values. Okay. Now, here is another patient. Red is pre-bronchodilator, blue is post-bronchodilator. You have the volume time graph and you have the flow volume loop. What is your diagnosis? Just look at the red one. Yes, severe obstructive airway disease, correct. After giving a bronchodilator, is there a change? Hardly anything, isn't it? There is almost no change after giving a short-acting bronchodilator. So, what is this patient suffering from? Asthma, sorry, COPD. COPD, you get poor bronchodilator reversibility. Here is a simple algorithm that you can use using the numbers of FEV1 and FVC to categorize a patient into normal, restrictive lung disease or obstructive airway disease. If your FeV1 upon FVC ratio is more than 70% and the FVC is more than 80%, this is normal spirometry. If the ratio is more than 70% and the FVC is less than 80%, then it is indicative of restrictive lung disease. On the other hand, if your FeV1 upon FVC ratio is less than 70%, it is obstructive airway disease for sure. If the FVC is normal, then it is mild or moderate obstructive airway disease, and if the FVC is less than 80%, then either it is severe obstructive airway disease or this is a mixture of obstructive and restrictive lung disease. And I told you why the FVC value is lower in patients of severe obstructive airway disease. This is the defining criteria for mild, moderate or severe for asthma and for COPD. So, for asthma you have the 60-80 rule, more than 80 mild, 60 to 80 moderate, less than 60 severe, and for COPD you have more than 80 mild, 50 to 80 moderate, 30 to 50 severe, and less than 30 very severe. Last two slides on how patients of restrictive lung disease look like. They look like a mirror image, but which is much smaller in size compared to that of a normal healthy person. There is no concavity anywhere. FVC value is low, peak flow value is low, all the values are low. As you can see here, a smaller or a shrunken normal is what is indicative of underlying restrictive lung disease. You can also use a spirometer to diagnose a large airways obstruction, whether it is extrathoracic or intrathoracic. If it is extrathoracic, then you can see that the inspiratory part of the curve is affected, and if it is intrathoracic, then the expiratory part of the curve is affected. So, by just looking at which curve is affected, the inspiratory one or the expiratory one, you can clearly understand whether this is intrathoracic or an extrathoracic large airways obstruction. So, this is what I wanted to share with you about spirometry. It is the gold standard diagnostic test for obstructive airway disease such as asthma and COPD. It not only helps you in making a diagnosis, it tells you the severity of the disease and also tells you the response to treatment once you have started these patients on appropriate pharmacotherapy. Thank you.